The heart attack risk your doctor never tested. Lp(a), Pelacarsen, Lepodisiran, Zerlasiran. There is a form of cardiovascular risk that affects roughly 1 in 5 people. You can exercise, you can eat well, you can have normal triglycerides, you can even have an LDL cholesterol level that looks reasonably controlled, and still carry a major inherited risk of heart attack, stroke, and aortic valve disease. This is called lipoprotein little a. Let's get going. So it's written LP, open bracket, little a, close bracket. That's how you recognize it. But we'll talk about it. So, LP little a. Most people have never heard of it. Well, I guess if you're on this channel, you probably have. Most standard cholesterol panels do not report it. And many doctors still do not order it routinely because if you're just ordering a lipid panel, it's not going to be on there. You have to really separately ask for it. That means millions of people are walking around with a genetically determined cardiovascular risk that has never been measured. But this field's about to change. Several experimental medicines, including Pelacarsen, Lepodisiran, Zerlasiran, can dramatically lower Lp(a). The numbers are impressive, but there's one question the pharmaceutical industry still has to answer. Does lowering the laboratory number actually prevent heart attacks, strokes, cardiovascular deaths? Today, I will show you what Lp(a) is, why it has remained hidden, who should be tested, what you can do today, and why the next generation of Lp(a) drug could become one of the biggest stories in cardiovascular medicine. Because your cholesterol results might not be telling you the whole story. As former Minister of Health, I learned that the most dangerous public health gaps are not always caused by a lack of technology. Sometimes the test already exists, the science already exists, but the system has not yet incorporated into routine care. Case in point, Lp(a), perfect example. This is not a new molecule. Scientists have studied it for decades. The test is widely available. Yet, awareness is down. Screening and treatment have been lagging behind the evidence. I test all my patients at least once. So let us separate what is already established from what is experimental. First, what exactly is Lp(a)? Okay, think of Lp(a) as a cholesterol-carrying particle related to LDL. Okay, like LDL, it contains Apolipoprotein B or ApoB. Talked about it a lot, got a whole episode on it. But Lp(a) has an additional protein attached to it called Apolipoprotein(a). That extra protein changes the biological behavior. Lp(a) appears to promote cardiovascular disease through several overlapping mechanisms. It carries cholesterol into the artery wall. It is associated with inflammation and oxidized phospholipids. And its structure may interfere with normal clot breakdown. So you see how this is a perfect storm? So this is not simply another cholesterol number. Okay, it combines features that may promote plaque formation, inflammation, and thrombosis. Elevated Lp(a) is associated with atherosclerotic cardiovascular disease, including coronary artery disease, heart attacks, ischemic stroke, and peripheral artery disease. It is also strongly associated with calcific aortic valve disease. That last point matters. Someone with a strong family history of premature heart disease or unexpected early aortic stenosis may have inherited high Lp(a) without knowing it. Okay, so really we need to look at family history, the actual test, when to do it. Here is what makes Lp(a), I guess, different, okay, than the rest. Your level is primarily determined by genetics. And this is also the reason you only take this test once, maybe twice, but you take it once. If you have it, you check the rest of your family. The gene involved is called Lpa, capital letters. Most people, Lp(a) level is established relatively early in life and remains reasonably stable. So this, again, means you test it once. That means like weight loss, exercise, and a better diet, although enormously important for your overall cardiovascular health, usually do not produce a major reduction in Lp(a). Sad to say. However, does that mean you don't do those things? Absolutely not, because now you're increasing the risk proportionally, right? It does not mean lifestyle is useless. So we have to, there's a nuance here. Lifestyle is the most important thing you can do. It's just that when you have an elevated Lp(a), we need to look further, and we might have to do more than just lifestyle. It only means that lifestyle cannot erase the inherent risk particle. Listen, you still want, excellent blood pressure, standard. You still want to avoid smoking, right? You still want insulin sensitivity. You still want a low ApoB burden. You still want to exercise and control visceral fat. In fact, those things may become even more important when you know you have high Lp(a). You cannot presently change the genes you inherited, but you can reduce the other risks accumulating around them. Key. So get the message right. Why is your standard cholesterol test missing it? A routine lipid panel generally measures total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. We are all familiar with this. Lp(a) is a separate measurement. It's a separate request. It must usually be ordered specifically, and this creates an enormous blind spot. A person, anyone, a patient may be told, hey, your cholesterol is fine. Doesn't mean much, but that statement may only mean that their standard lipid markers are within conventional range. It doesn't tell us anything about Lp(a). It doesn't tell us anything about their genetic profile. It does not mean that Lp(a) was tested. It does not mean ApoB was tested, which needs to be tested. It's another one. That's another episode. And it certainly doesn't mean that their total lifetime cardiovascular risk has been fully characterized. This is one reason I prefer a deeper cardiovascular assessment. At minimum, that can include, all right, we'll go through a list here. So write these down. Standard lipid profile, yes. ApoB, a must. Lp(a), once. Blood pressure, glucose regulation. And let's not forget the family history. And depending on the individual, imaging, such as coronary artery calcium scoring, or clearly, much better. No single marker tells the entire story. We have to get the complete picture. There's many systems at play. This is where patients often become confused because laboratories use different units, okay? With the Lp(a) may be reported in milligrams per deciliter or in nanomoles per liter. These units are not directly interchangeable. Using one universally accurate conversion factor. Okay, so yeah, you really need to kind of compare apples to apples. Because Lp(a) particles vary in size between individuals, as a practical clinical guide, an Lp(a) level of approximately 50 milligrams per deciliter or 125 nanomoles per liter and above is commonly regarded as a significant risk-enhancing level. So let me go to that again. Practical guidelines. But speak to your physician about this. 50 milligrams per deciliter or 125 nanomoles per liter and above is risk enhancement level. But cardiovascular risk does not suddenly appear at one magical cutoff. Risk generally rises across a concentration range. A result should therefore be interpreted alongside the patient's total cardiovascular profile. So we need to look at all sides. Do they already have coronary artery disease? Did a patient have a heart attack at 48? Is ApoB elevated? This is very important. Do they smoke? Do they have hypertension? Do they have diabetes? Is there evidence of plaque on imaging? And this is where clearly comes in. Or CAC score, which is a rough one. The same Lp(a) result may lead to different clinical urgency in two different people. So who should be tested? There's a strong argument for measuring Lp(a) at least once during adulthood. Okay? Testing becomes especially important when there is premature cardiovascular disease, a strong family history of heart attack or stroke, familial hypercholesterolemia, the usuals, recurrent cardiovascular events despite reasonable LDL control, unexplained aortic valve calcification or stenosis, or a risk profile that seems worse than the conventional cholesterol numbers would predict. Because listen, Lp(a) is largely genetic. A markedly elevated result may also have implications for parents, siblings, and children, so they need to be checked. This is sometimes called a cascade screening. One person's blood test can identify risk throughout the entire family. So is it important? Yeah. So what can we do today? At this time of this recording, this is a widely approved medicine, especially indicated to lower Lp(a) for the purpose of preventing cardiovascular event. That does not mean we do nothing. It means we become aggressive about the risk we can already modify. The first objective is usually to reduce the concentration of ApoB containing particles as much as clinically appropriate. That may or may not involve statins, ezetimibe. Am I saying that right? Ezetimibe? Yeah. Better one is PCSK9 targeted therapy. It's cleaner, it's better, and it actually lowers the Lp(a). And in selected patients, other lipid-lowering medications. Statins generally do not lower Lp(a), and in some patients, they may modestly increase the measured level. So I don't like statins for this. But that does not make statins useless in someone with high Lp(a). Your doctor will look at that. Statins reduce LDL related cardiovascular risk. Remember, the objective is not merely to improve one's isolated laboratory markers. The objective is to reduce the patient's total probability of a cardiovascular event. That's what we're going for. So that PCSK9 inhibitors can produce a modest reduction in Lp(a), commonly in the range through 20 to 30%, while substantially lowering LDL cholesterol. Good, right? The lipoprotein apheresis can reduce Lp(a) in a carefully selected patients, but it is invasive, resource intensive, and not a practical population-wide solution. Niacin can also lower Lp(a), but it has not earned a routine role for cardiovascular event prevention because lowering a biomarker is not enough, right, to ensure clinical outcomes and tolerability, right? That does not justify the treatment. The lesson is central to everything that follows. Okay, lowering the number versus saving a life. That's what we're talking about. Modern LPA therapies can make the laboratory graph look spectacular, but medicine has been fooled by surrogate markers before. A surrogate marker is a measurable biological variable used as a substitute for clinical outcome. Lp(a) concentration is the surrogate. Heart attacks, strokes, cardiovascular deaths, the outcomes are what matters. The genetic evidence strongly suggests that Lp(a) is causal, not merely correlated with disease. So it's a causal effect. It's serious. So this gives scientists a solid biological target. But we still need randomized outcomes trials to demonstrate that pharmacologically lowering Lp(a) reduces actual cardiovascular events and determines how much lowering is required. We need to see how much. This is the finish line. Not a 90% reduction on the laboratory report, but fewer patients having heart attacks. Okay, Pelacarsen. Pelacarsen, and we talked about this, I'm bringing it back up, is an antisense oligonucleotide. That sounds complicated, but the concept is straightforward. Your liver receives genetic instructions to produce Apolipoprotein a, Lp(a). Okay? Pelacarsen binds to that messenger RNA carrying those instructions. By interfering with that message, the liver produces less lipoprotein a, and circulating Lp(a) falls. Earlier studies have demonstrated substantial reductions, but the decisive study is called the Lp(a) Horizon. It is a large phase 3 cardiovascular outcome trial enrolling patients with established cardiovascular disease and elevated Lp(a). The fundamental question is not, can Pelacarsen lower Lp(a)? We already know it can. The actual question is, does treatment reduce major cardiovascular events compared with placebo? Until the complete results are available and properly analyzed, Pelacarsen remains an investigational therapy. Very promising. Absolutely. Is it proven to prevent cardiovascular events? Not yet, but they're close. Let's talk about Lepodisiran. Lepodisiran uses a different technology called small interfering RNA, or siRNA. Rather than binding the protein itself, it silences the liver's production instructions upstream. The appeal of siRNA is durability. A relatively infrequent injection may suppress production for months, so adherence is great. In a phase 2 study, Lepodisiran produced extremely large and prolonged reductions of Lp(a). At the higher study doses, average reductions approached the mid-90% range over the principal assessment period. That is one of the most dramatic biomarker effects in the field. But again, a 94% reduction in Lp(a) is not the same as a 94% reduction in heart attacks. So we need to assess the number, but we really need to look at the outcome. Those are completely different claims. The phase 3 ACCLAIM-Lp program is evaluating whether Lepodisiran can reduce cardiovascular risk in people with elevated Lp(a) who either have cardiovascular disease or are at substantial risk. You know, this trial really matters. The long dosing interval could become a major advantage once it's proven safe and effective. Like, imagine controlling a major inherited risk factor with only an occasional injection. Man, this could transform adherence, and adherence is one of our biggest pitfalls. However, we must first see the outcome data, longer safety, and eventual, pricing. Next one up is Zerlasiran. Zerlasiran, previously called SLN360, is also a small interfering RNA therapy. It targets the messenger RNA responsible for Lp(a) production in the liver. Phase 2 research demonstrates substantial and sustained reduction in Lp(a), supporting continued development. Once again, the biological signal is impressive, but Zerlasiran is earlier in the race towards definite cardiovascular outcome evidence than the most advanced programs. Its development pathway, partnerships, phase 3 execution, and eventual outcome data will determine whether it becomes real clinical option or simply another molecule that lowers a compelling surrogate. The field, this is the good news, the field is moving quickly, but patients should not interpret movement as approval. We also have, and this is in a previous episode where we're kind of, on a genetic level, mutating genes so that cholesterol stays down permanently. Look at that episode. These are options. We're at a crossroads, and it's great news for the disease that kills most people around the world. So none of these compounds should be purchased through an online peptide vendor, underground laboratory, or so-called research chemical company. These are sophisticated gene silencing medicines, not supplements, not wellness, none of that. Okay, there's one drug that I don't want to ignore, Olpasiran. Olpasiran is another siRNA medicine targeting Lp(a). It has produced profound reductions in Lp(a) and is being evaluated in a major cardiovascular outcome trial. I have focused this episode on Pelacarsen, Lepodisiran, Zerlasiran, because those are selected candidates. But scientifically, Olpasiran belongs in the conversation. This is not a three-horse race. It's an entire emerging therapeutic category, and that's what I'm trying to say. And competing may ultimately be good for patients by improving dosing, access, and pricing. The big unanswered question, of course, is before declaring victory, we need answers to several questions. First, how much must Lp(a) be lowered to create a meaningful reduction in events? Again, we're focusing on the events because genetically elevated Lp(a) acts across a lifetime. It is possible that a very large pharmacological reduction will be needed when treatment begins later in life. So it depends when you're beginning, where you're at with the disease process. Second, who benefits most? People with established cardiovascular disease, people with extremely high Lp(a), younger people, like before the plaque develops as a prevention, or certain combinations of Lp(a), ApoB, and imaging evidence. So we really have to know, where this fits. Where's the sweet spot? Third, how early should treatment begin? A drug tested in older adults with existing disease does not automatically have proven lifelong benefits in a healthy 30-year-old. Number 4, we continue. What will the treatment cost? Will insurance pick it up? A therapy can be scientifically revolutionary and still fail at a populational level if only a minor few can afford it. Number 5, what are the long-term safety consequences of driving Lp(a) to an extreme low concentration? Now, luckily, we have people that are born with this, so we have an idea. People with naturally low Lp(a) provide some reassurance, but deliberate, sustained pharmacological suppression still requires proper surveillance, okay? Because we're pharmacologically suppressing it. It throws off everything. Our bodies are connected, right? You can't just take one element, slam it down, and then think nothing else is going to happen. Don't panic. Do not order experimental RNA therapy from the internet, and do not allow anyone to tell you there is nothing you can do. First, confirm the units and understanding the degree of elevation. Second, examine your family history. Third, measure the risks surrounding it, lifestyle. That includes ApoB, blood pressure, smoking, glucose regulation, kidney function, and body composition. Yes, body composition. If you got visceral fat and you got a lot of fat, you're pushing this envelope. Fourth, discuss whether cardiovascular imaging would improve decision making. Lower modifiable risk aggressively and appropriately. And six, pay attention to the outcome trials, but do not confuse press releases with completed medical advice or completed, medical evidence. High Lp(a) is not a prediction that you will definitely have a heart attack. It is information, and information becomes powerful when it changes what you do next. So, get tested. Listen, for decades, Lp(a) occupied a strange position in medicine. We knew it was inherited. We knew it was associated with cardiovascular disease. We could measure it, but we had no highly effective targeting treatment and no definite proof that lowering it would prevent events. That is why so many clinicians stopped at interesting, but what do we do about it? That era may be ending. Pelacarsen, Lepodisiran, Zerlasiran, Olpasiran, and other therapies are forcing cardiovascular medicine to confront a risk factor it has largely ignored. But the most important breakthrough available to you today does not require waiting for new drugs. It is one blood test. Ask whether your Lp(a) has ever been measured. Thank you. Subscribe, ring the bell notification, invite friends. This is really important.